All right, welcome to another Around the County with Supervisor Jim Desmond. I'm Miles Himmel, Communications Director for District 5 and County Supervisor Desmond. And we have a special guest with us today. We've got Dr. Monica Gandhi, infectious disease and HIV doctor at UCSF. Doctor, do I have that all right? Is that
yes,
your bio?
That's right.
Well,
yes.
Awesome. Supervisor Desmond and I, we came across this op-ed, and then I read a little more about you, but I wanted to talk about this op-ed first here in the Wall Street Journal. Let's start with the headline. COVID will soon be an endemic, thank goodness. I think it's fascinating because it's something that our office has talked about as well. If you don't mind kind of explaining what an endemic is versus a pandemic and why you think that is.
Yes, so I didn't write the title of the editorial, but I think it was interesting. And I don't know when this will happen, but hopefully soon. So essentially, we think about the strict definitions in infectious disease epidemiology. A pandemic is when a new infection is affecting all continents, is found basically everywhere. Then an epidemic is what's going on in the region. So let's call the United States the region. And an epidemic means that you have higher than expected rates of COVID in this case. And of course, we don't know what expected rates are because this is a new infection, but we know that what we've seen in this country was not what was acceptable, which these high rates of deaths, and unfortunately 718,000 deaths from COVID. And so as we've vaccinated, what's been happening is that we've seen the death rate decrease. We certainly had increases with the Delta variant, but death rates, hospitalizations, and cases have all been going down really since mid-September, or actually the beginning of September after the Delta wave. And so then the question is, when do we get to a point where it's endemic? And what endemic means is that it doesn't cause undue burden on the healthcare system and that we just manage it like we manage so many other respiratory infections. And when the hospitalizations have gotten low, which really is the promise of vaccines, because what vaccines do are prevent severe disease, then the healthcare system is not overwhelmed in any way. And we manage COVID-19 like we manage other respiratory illnesses. We now have molnupiravir coming, which is an antiviral that we can treat people who've declined vaccination right now. We have vaccines for anyone, childhood vaccines are coming in a couple of weeks. So we basically get it down to a level where we just live with it. It's called control. And examples are like pertussis, which is whooping cough. We've lived with this being endemic, being controlled, and it doesn't disrupt society.
Well, is that, okay, did I hear, is a pandemic and an endemic and an endemic? Are those three different demics, I guess, or
So pandemic just means it's everywhere, which the WHO declared this as a pandemic very early on, March 26, 2020. But epidemic means what's going on in the United States. So that's the region. Our region is the United States, and we have an epidemic of COVID. And then when it gets to what's called control, we'll call it endemic. And what endemic means is it's going to be I don't think it's possible to eradicate COVID-19. It's very contagious, especially Delta. It looks like a bunch of other respiratory infections, and it has a long infectious period. So just like measles, it's not likely to be eradicated. In fact, we've only eradicated one human disease ever, which is smallpox. But we can still get it down to a low level where we call it controlled. And controlled means we're always vaccinating, we're always keeping on top of it, but it doesn't disrupt society like this was such a disruptive infection.
Wow. Well, and I just, one of the things that we've been putting out from my office is that we've got to learn to live with this, with COVID-19 and still get on with our lives while we're protecting each other in different ways, I guess, however that evolves. But is that kind of, what do you see, I guess, living with it? You know, the controls and things like that, continuing vaccinations, but how do you picture living with this long term?
So I picture normalcy in terms of living with it long term, because if you think about, I think the two infections to compare it to are measles and pertussis, which is whooping cough. They both have effective vaccines. Measles was developed in 1963, even though measles was described in the ninth century. So we lived with it for a lot longer before we had vaccines. Very lucky to have gotten vaccines. And then whooping cough has a vaccine and a treatment. So there's an oral antibiotic that we can use for it if people decline to vaccinate or if a child's too young. And so what we do is those are totally controlled. We have a treatment, we have hopefully prevention, like meaning prevention is always worth more than treatment. So we have these excellent vaccines and we live normally. We don't mask, we don't distance, we don't close down society. We live normally with the virus, but it becomes the problem of physicians and of infectious disease doctors, just like measles is a problem of us, but the country does not think about measles that much. They'll read about a measles outbreak in an unvaccinated community, and that will be noted, but they don't think about measles. And that's where we want to get to. And that's where countries have gotten to. Denmark, Norway, Sweden, Portugal, Italy, France are all getting there. We're all in the transition period to get to endemicity.
Ah, wow. Well, that's so you don't think we're there yet, I guess, in the United States.
It depends on the region. I mean, you could argue that California is where Denmark is because they have such high rates of vaccination. That Denmark on September 10th, 2021, opened fully, no restrictions on life, no masks indoors, nothing. And they had a 74% total vaccination rate of their entire population, or 88% above 18. California is approaching those levels. We have very high levels of vaccination, but that's certainly not true of other regions of the country. So we're very uneven. Puerto Rico is probably has our highest rates of vaccination actually of our territories and states. Actually, Puerto Rico is ignored that. It's doing really great. So that's where we are. It depends on the state.
Oh, I see. We're in San Diego County. We're at 80% right now total vaccinations, and then I think 90% with people that have gotten it at least the first shot.
That's great.
And you mentioned there's a couple of treatments, I guess, a monoclonal, and I'm familiar with it. We've done a podcast on. I'm not a doctor, but there are other treatments? Is there 2 or 3?
There's really only right now. There's really only monoclonal antibodies, which is an outpatient treatment. Pretty hard to give. Intravenous or subcutaneous injections have to watch. But what's coming is molnupiravir, and that's really the only treatment that's on the horizon. That's very exciting, though, and it is an oral outpatient treatment for COVID. So it'd be like giving Tamiflu for flu, except that it's actually more effective than Tamiflu, at least in the initial studies. So you see someone, they're not feeling well, you give them molnupiravir, and you send them on their way if they have mild to moderate COVID. So it's sort of amazing to have an oral option, 5 days, twice a day, and you're done. And it reduced, we just have a study that it reduced hospitalizations by half. There were no deaths in the molnupiravir arm, 8 deaths in the placebo arm from COVID. And it's already, Merck, which is the company, has already applied and put in their paperwork for emergency use authorization from the FDA.
Wow, that's great. Could you say that again, or slow, monoplural?
Yeah, MOL, MOL, NU, piravir, PIRAVIR, molnupiravir. They may have an easier to say name eventually, but it's molnupiravir. And it's an outpatient antiviral, very specific for the virus or for all RNA polymerase viruses. And it's an antiviral as opposed to kind of something non-specific. So it's very, very exciting.
Doctor, I wanted to ask you a question, and I guess this is kind of looking ahead, which I think we all want to do and get some positive news. And maybe it's based on the medicine you were just talking about, but and I don't even know what numbers to believe. I mean, there's different numbers, and that's kind of half the battle. Do you see moving forward that they'll need more booster shots? And the reason I ask that, right, is some of the questions we're hearing or some of the people and some of the tweets is there's breakthrough infections, the vaccines are wearing off, they're wearing off, you need boosters. Obviously, we're seeing boosters. Do you see it 2-3 years down the road, you need a booster maybe every year, maybe like a flu shot? Or do you think some of these new treatments will help? And I know things are always evolving, but I'm just kind of curious.
Just in terms of how the vaccines work, I don't see us needing multiple boosters at all like that, because just to remember, coronavirus and influenza are very different. Coronavirus doesn't usually mutate very fast. And actually, if you think about it, the number of variants that have really emerged with this much degree of transmission is not crazy. Delta variant has really been around since late 2020. It really rose in India in the beginning of March, and it's been the dominant variant for almost 7 months. I mean, we're not seeing something else that can compete with Delta. The polymerase itself of coronavirus doesn't mutate that fast. We've just had so much transmission. And then influenza does mutate very fast, and we need a shot every year. But if you think about what we've seen with the immunology research with these vaccines, we really have good data that they produce what we need to protect ourselves in the future, which are called memory cells. They produce memory B cells. They've even done lymph node biopsies of people who've gotten vaccines, and you can see nice memory B cells forming. They form T cells, which provide durable immunity, especially if they go into the memory bank, which they do, durable immunity for years and years. There's a study that measles vaccine gives you T cell immunity for 34 years and counting. There's a study from SARS that T cells are still lasting 17 years, because SARS was in 2003. So I don't think we're going to need a booster every year. I think what happened here is we had high rates of transmission. There were more mild breakthrough infections. No vaccine is impermeable. You can have breakthroughs if you see a lot of virus. It's like being surrounded by virus and you can't totally protect yourself. But once our transmission rates go down, which they are, California's had the lowest rates of transmission in the country since around September 2020. I mean, we were holding this record for almost a month that we're doing very well with our case rates. Then you're not even susceptible to getting a breakthrough. And the immunologic research shows they should last for a long time.
What, just to follow, and again, that makes total sense. And I pray that that's the case. What's going on in Israel? Like, why, what's the problem there?
I think 3 things happened in Israel. One is that they had very low rates of natural immunity. They had a seroprevalence study in September that showed they had a 3.8% people infected, because they really have a very small country and they didn't have a lot of COVID. We had a lot of COVID. We had a lot of COVID in California. We had a seroprevalence study in February from the California DPH that showed we had a 38% seroprevalence and 45% in LA County, for example. I don't remember exactly what it was in San Diego, but it was something like 38% across the whole state. So we had we had a terrible winter surge, and we had higher rates of natural infection. Natural infection with a vaccine that's called hybrid immunity, that's stronger and more durable. Second is that they only gave Pfizer. That was just, they had a deal, and they only gave it every 3 weeks apart. That is the worst way to give a vaccine. Unfortunately, we need to think about spacing our Pfizer longer. Canada, UK spaced their duration out by like 6 to 7 weeks. And there was just data from last week that showed that you have 92% vaccine effectiveness if you spaced it out 7 weeks, and only 82% if you spaced it out 3 weeks. So second is the spacing. And then third is they have mixed populations. They looked like they were doing great. They were, and then they stopped vaccinating, and they have communities that are unvaccinated. They don't have the 80% rate that you quoted me, Supervisor, in San Diego. And they really fell down with vaccinations. And when you have mixed populations, groups of people that are not vaccinated, lots of more spread. So they are not our country. We have different vaccines. We spaced out Moderna, thank goodness. Like, we have better vaccines. We need to space out Pfizer. That's why I think it's the Pfizer people who probably need the booster. Johnson & Johnson for sure. And then I think we're not going to need boosters every year, maybe 10 years. Let's see what happens with transmission rates.
Wow. Very interesting. I didn't realize that, because I think, I had the Pfizer, and it was like, I think 2 weeks. It was only spaced out like 14 days. But it's good to hear that they're learning and studies are being done and reflecting on what is that the best, I guess, interval or not?
Yes, yeah. It probably never was. Just principles of vaccinology is it's always better to space. Like, no childhood vaccine is every 3 weeks, but we really got data over the last 2 weeks from Canada. It's likely more safe and also more effective if you space it out. So I hope the FDA will consider making that recommendation for children.
Well, it's very interesting. we're kind of getting towards it time here, and just curious, is there anything you wanted to add, or just kind of let people know? Because we were interested in your editorial that in the Wall Street Journal, and thought it was very well written and very good. That's why we contacted you. So you have anything you kind of want to say to people that before we sign off?
Well, I do want to say that I think, unfortunately, Delta is very transmissible, and we have a lot more natural immunity that occurred throughout the Delta surge in the United States, as well as vaccine-induced immunity. We actually had about 38 million additional vaccines going into Americans since the Delta surge, and we had at least 10 million cases, and that's probably an underestimate of infections by at least twofold. So we're just getting more and more immunity. And I think what I really wanted to point out in that editorial is that though mass distancing, contact tracing, testing, and ventilation, they're all tools, the fundamental way to get through a pandemic is immunity. And as we get higher and higher rates of immunity, we went into Delta with at least 62% immunity to the coronavirus, because there was an Annals of Internal Medicine study that showed us that at least 62%. You add on the immunity that we've gotten from Delta, and I think we're getting very high levels of immunity in our population. I can never say never, but I don't think we're gonna have another surge of coronavirus. And that is really good news going into the holiday season. And I think we just need to always increase our vaccination rates, but we're getting there.
Good. Well, when you say immunity, is that the natural immunity or immunity from the vaccine?
It's interesting. It's both, because obviously natural immunity also confers immunity. I mean, in fact, it depends on the setting. It depends on the vaccine. Sometimes natural immunity is stronger than vaccine-induced immunity. That was a study from Israel. If we give the vaccine right, vaccine-induced immunity is stronger than natural immunity. And also it depends on your severity of your natural infection. So all of that put together, we have overlapping, like people got vaccines when they had natural immunity, which is good. That's called hybrid immunity. We in California have a lot of hybrid immunity. Hybrid means you got both. I wish that we could have gotten the vaccine first, but we couldn't develop the vaccine the day after the pandemic started. But vaccines plus even having natural infection on top of it, this is called hybrid immunity. These are the places that are doing great. And I think California is doing great. I think that places with that hybrid immunity, like Denmark, is doing great. Italy is doing great because they had both. And I think these are the countries and the places that are going to have durable, long-standing immunity. I think we're really getting through it in California. And I just wanted to give people that hope, because it's been a long, long pandemic.
Like that. Wrap it up on some positivity, doctor. I appreciate it. Some good news. Thank you so much. I know your busy schedule, and I know you got a lot going on. So we really appreciate you coming on, sharing some insight, and we'll be sure to send this to everybody here in San Diego.
Thank you for having me.